Hello, and welcome to the Health GoLive webinar series. Today's episode is brought to you by our friends at IMO Health. We would like to remind you that the Q&A feature is available, so feel free to send in your questions and comments throughout today's webinar. We would love to hear from you. And with that, I will turn it over to our moderator, Grace Vinton.
Hello, Health IT family. I'm Grace Vinton, a healthcare PR pro, a patient advocate, and podcast host of High Tea with Grace, a podcast where we spill the tea on HIT. I'm honored to welcome you to today's webinar, and the title of which is my personal life mission: Stop Treating Patients Like Data Points. We're going to be diving into how health tech leaders are transforming data practices by keeping patients, not just their data, at the center of innovation. You'll hear from experts driving real change in AI, clinical workflows, value-based care, and they're going to be speaking about practical takeaways for designing tech that improves healthcare for all. So let's introduce them all and bring them on to a video here. We're going to be learning from Heather Miller. She's the VP of Partnerships at Suki. PJ Helmuth, who is a doctor and the Chief Medical Officer at Lumeris, and Ivana, who is the COO at IMO Health. So thanks so much for joining me, guys, and let's dive right into the topic. So tell me, what is your organization's mission, and how does it reflect your commitment to human-centered healthcare innovation? Ivana, I'd love for you to start us off.
Sure. Thank you for having me, Grace. So IMO Health has been in business now for over 3 decades, and our initial mission really set out to empower providers at the point of care while they were navigating the transition from paper medical record to digital medical record, and really enabling them with clinical terminology so that they could capture data in the way that they intend without having to worry about all the coding implications of that. As time went on, that data, of course, that clinical data is used throughout the healthcare ecosystem. We had significant opportunity in helping to standardize and make consistent clinical data for various data analytics companies, for life sciences organizations, and for payers, so that there was really an understanding of what the clinician's true intent was. In recent years, I would say with the advent of generative AI, our mission is evolving into really being one that is helping ground these AI initiatives and really making sense of AI so that it is accurate and allows for the entire health tech, life sciences, payer industry to more rapidly innovate.
Fantastic. That is awesome. It's a great mission to have. So thanks for joining us today. And PJ, tell us a little bit about your organization's mission.
Yeah, so I'm with Lumeris. The mission at Lumeris is to create a healthcare system that primary care physicians would want for their families, and I love that our way to articulate the mission in that it notes that there are multiple stakeholders in this mission that we have here, and that it's taking the view from primary care physicians, but also noting that it's delivering the care to a population and to individual patients. And I think the thing that is sometimes difficult in healthcare, it's easy to sort of lose focus of all the different stakeholders that we need to be helping here, and that includes, employers, payers, the patients, the physicians, the health system, and one of the interesting things about the way that Lumeris sort of grew up as an organization, it started with a group of physicians. They started a health plan, which is now a Medicare Advantage plan with more than 60,000 beneficiaries. And then because of their success in value-based care, that they branched off into a value-based care enablement program with more than 1 million patients in risk contracts over across the country, and knowing that you have to build the technology in order to manage risk, and to support patients and families in that, it really became a very tech-forward company. And now we have an agentic AI system which we're building and deploying for primary care transformation. And I'll be honest, I'm new to the organization, having just joined about 6 weeks ago, and I'm really excited to be on this part of the journey. Again, thinking about how we've gotten from, just practice of medicine before the advent of EHRs to realizing the importance of technology, and now to moving into artificial intelligence and agentic systems that are going to transform the way that a primary care practice interacts with its patients. So a lot of exciting changes here, like for much of the industry, but really focused on that care delivery for the population.
Fantastic. Can't wait to learn more about that today. Heather, would love for you to introduce yourself and say tell us a little bit about your organization's mission.
Yeah, of course. Heather Miller, and I am the VP of Partnerships and our platform business here at Suki. And our mission is actually very simple, and it's been consistent. We're an 8-year-old company, and we live and breathe this every day, which is to make healthcare technology invisible and assistive to clinicians so that they can do what they love, which is take care of patients. What really resonates with me about our mission is the fact that our goal is to meet the provider, meet the nurse, meet them where they're at, not necessarily push something on them, yet another task, another AI technology, but we want to be assistive. We want to be just in the background. They don't even have to worry about it, and it just works. And, selfishly, that allows them to be present with the patient, which is exactly why they got into, healthcare in the first place. They didn't get into it for learning how to chart.
So let's dive right
that's
into
Suki.
it. Very interesting, and I can't wait to kind of learn from you guys today, and I'm sure everybody's excited about that. I'd like to remind everybody that you can insert your questions into the chat. We'd love for this to be kind of an interactive conversation, and would love to hear from you about what questions you have for these fantastic folks. And also feel free to put your LinkedIn into the chat as well. That way you can get connected with the people who are here and stay connected even after this and talk about this topic together. So Heather, let's kind of
Yeah.
talk about what are some of the risks or consequences an organization like yours faces when clinical data is inaccurate or stripped of context?
Yeah, great question, because there's a lot of risk. Whenever clinical, like the output, the information, whatever it might be that's coming out from that technology, that AI, is even off a tiny bit, it really creates risk. And for us at Suki, our job is to generate those high quality AI outputs that the doctors and nurses can trust. And as we all know, as humans, trust is very easy to break and very difficult to rebuild. So we really don't have multiple chances with the doctors and the nurses. And so if the data that we capture or that we produce is inaccurate, it's missing a very important patient context, it can lead to not only poor documentation, but it could affect patient care. And so that's why it is just so important to, as a healthcare tech company like ourselves, like IMO, to build that rigorous process, because we have to ensure that that quality is very, very high, very, very accurate, so that they can trust us.
PJ, I'd love for you to add to that. Like, what are some, risks or consequences your organization has, faced or they're worried about if that data is not accurate and fully clinically validated?
Yeah, it's a great question. I think, as with most organizations, we continue to struggle with the credibility that comes with having accurate information, and the problems with credibility when you don't. And that includes all of our stakeholders. So if our agent reaches out to a patient that says like, it looks like you're due for a colonoscopy, but it happens that they just had a colonoscopy, or that they don't need a colonoscopy for some other medical reason, then that patient is not going to trust that the agent knows them and knows what's going on. That always already happens with humans, right? If our organization reaches out and doesn't really understand that patient, and it's really not just, as to your point previously, Grace, not just the data point, but people just want to be known and understood as who they are. When we don't meet that mark, patients don't trust us, and they don't necessarily come to us when they need us. And so we see that as an important aspect. I'll just say sort of incidentally that I think healthcare is the one place where we're all kind of accustomed to putting up with bad data. Like if my banking solution didn't do a good job with knowing what happened when I withdrew money in Portugal, like I'd have a problem. But we sort of tolerate directional information in healthcare in a way that I think we need to get past at some point. We have to get better at sort of our expectations for the interoperability and the ability to send information across systems and to different end users. Because again, it's not just the credibility with patients and physicians, but also it's the patient safety aspects that can come from that as well.
Yeah, especially as you mentioned, developing agentic AI solutions. What are some of the risks and consequences with that?
Yeah, exactly. I think, as we look at our first out of the gate solutions, we see this, we know that this is a high risk place to have an agent reaching out to and interacting with a patient. So, the way we sort of conceive of it is that there's this world of data about this patient. We want to develop a picture of that patient with data inputs from lots of different places. We have to clean that up because a lot of those data inputs come to us in ways that just aren't necessarily able to be, they can just be dirty and not necessarily in ways that we can use them. So we need that to be usable, but to give us a picture. And then the agent's going to reach out, talk to the patient, gather more information. We need to put that together and help to bring insights to the care team. All of those steps require some validation and review for us. And so that's the place where we see really exciting opportunity, but also risk. And we know we just have to do it right.
I just got a great question in the chat for y'all, and I just would love to start with this one. In healthcare, and I'll have Ivana start with this one. In healthcare, there's so much data, but how do we tell that story? What are your top tips for how to present data to leadership or bedside providers or different audiences? Ivana, I would love for you to talk about that data story and the importance of accuracy in that.
Yeah, I mean, when you think about a longitudinal view of a patient, you really need to, one, understand the totality, the comprehensiveness of that data. And then you need to standardize, normalize that data so it's all consistent. And then you're able to run analytics against it. There is so much complexity in that. I mean, like PJ just talked about, it's actually getting access to where that data is, and even the interoperability layer of how that data gets shared. So much fidelity gets lost in translation. But without that, you really don't have an accurate view of the patient. And that alone causes so much work, administrative overhead, and burden for a hospital, a health system, because they really can't accurately report against their populations.
Yeah, and as we think on that kind of similar strain, what steps has your organization taken through innovation, technology, partnerships to improve the accuracy and context of the patient data and that patient story? And what approaches are working well for you guys? And I'd love for the rest of you guys to answer this question as well.
Yeah, so IMO Health is in a unique situation in that 94% of providers in the country use our terminology and our technology every day. And so we're seeing trends in real time on what providers are searching for, but also how documentation is evolving. And one of the things that, we talk a lot about Gen AI already, that we've noticed is out of the box foundational large language models are not very accurate in healthcare contexts. So we're constantly running tests, of course, around the accuracy of just basic ICD-10 coding, taking a note, pulling out relevant entities and resolving them to ICD-10 codes. At best, they're getting to about 65% accuracy. And that doesn't include secondary codes. So you're talking about very basic kind of coding. So when I mentioned at the beginning, thinking about IMO Health as a foundational layer, of course, we're doing innovation internally with product development and all that. But when we think about innovation, it's more about being that foundational layer that powers these large language models. And when we do that, we see levels of accuracy in the 98, 99% range. And that includes all that specificity of secondary codes as well. And that's where we're focused.
That's so cool and very inspiring to all of us that this is being done to kind of reduce that patient being seen as a data point, right? Because the more accurate it is, the more true it is to the actual human being on the other side of it. So Heather, can you tell me a little bit about what steps you all are taking through innovation, technology, partnerships, however you want to see that question, to improve accuracy and context?
Yeah. And I looked at quickly the chat that had a question, and I think this will get to how do we handle all the different inputs, the signals that we're getting, whether it's from EHRs, it's from public data, it's from payer data, pharmacy, like how are we handling all those signals? And so here at Suki, we actually spent a lot of time and resources working on the foundation, which we're calling our clinical knowledge graph. So if you think about this foundation, we are feeding in these different signals. EHRs is a big one. Obviously, we're getting the information from them. We're working with public data from PubMed, eventually payers. But this idea that Heather Miller is a patient, I didn't just go see Dr. Vinton, and you only know about what I'm talking to Dr. Vinton about. It's really about understanding the fact that I was in the ED 6 months ago. I just had a child, or I have some previous problems and diagnoses that the doctor needs to know about. And in order to do that, you have to normalize all this data. So you have to build, which is what we have done with this clinical knowledge graph, contextual awareness, whether it's diseases, it's socioeconomic status, it's Heather Miller's went to the ED, but we have built this normalization layer so that as we plug more inputs in, we're able to understand that patient in such a more robust way, therefore providing that to the physicians.
That makes so much sense. And PJ, I'd love for you to answer this question too. Are you guys doing partnerships? Like, how are you getting to this end goal of improving the accuracy of the data?
But I would say that a lot of what we're doing is very similar to the work that Heather just described. In order to reach out to a patient or to summarize things for a clinician, we need to understand more about the patient, and it has to be from all of those different inputs, and that is a challenge. Just getting access to that information, and then figuring out how to sort of normalize it, put it together, and gather insights from it. I think one of the questions here was even about things like wearables. Of course, we're having conversations and discussions about it. I'll say as a physician, my patients will sometimes come in and like, what do you think my heart rate variability is down? I'm like, nobody ever taught me in medical school how to look at your heart rate variability, but that looks cool. So I think there's a lot of things which are just really cool and interesting. The question is, does cool end up being a valuable signal for healthcare outcomes? And if so, how? And as a physician, I don't want to look at your heart rate variability from yesterday. That's too much data. I need that to be aggregated. I need to have an insight that's developed. I need to figure out what to do with that. And that's the challenge that we see is, there's always a build it, buy it partner question in all of these things. But as we get access to more data, what are the insights that really drive outcomes and really make a difference versus just kind of cool? And I think there's a whole lot for us to learn here. We're on this journey, and I think there's still a whole lot for us to learn here about where we need to make the biggest bets.
Absolutely. And it's interesting that you both kind of experienced those similar challenges. Heather, are there any other challenges that you've experienced kind of on this road to improving that data quality that you've seen kind of consistently with customers you've worked with or partners? You're still on mute. Oh, there you go.
Sorry. Yes. Oh my gosh. One of it's one of the biggest challenges we've had, or we've seen over the last, I would say, 18 months as generative AI has really taken off, is who defines quality, right? A quality outcome, a note, et cetera. That output can be subjective. So how do you measure that? And so we at Suki have taken the approach of really grounding ourselves in the PDQI-9, which is essentially a framework that looks at different outputs and basically rates it on these things like clinical specialty relevance, clarity, completeness, accuracy. But we have a two-tiered system, both automated and human review, where we're looking at these different areas to ensure that our quality is the highest it can be. But definitely from a challenge standpoint, this is all new. Everything is like, this is evolving every day. And so we've really taken that stance of grounding ourselves in the standard of the PDQI-9.
And it also seems to be there's this kind of larger data governance challenge too.
Yes.
So what are your thoughts on that? And if anyone else has something to say on that, just raise your hand.
Yeah, I'll just give a quick kind of high level. There's no question, not only the government, but also individual health systems, healthcare IT companies, everybody is struggling to come up with, one kind of standard to data governance. It's not just about where is the data, but it's how is it used? What does the output look like? How do you ensure you're not inputting bias into it? I don't think we're there yet, to be honest. But the good news is there's a lot of really smart people working on this to ensure that we're getting it right.
That's fantastic. Now, I kind of want to bring this back to PJ, and then we'll add in Ivana after PJ. But PJ, there's a question in the chat here. In your experience, what are the biggest organizational or cultural barriers to implementing human-centered design in health tech? That great old physician experience and background. Have you seen companies successfully overcoming some of those internal organizational and cultural issues that they have implementing these things?
Yeah, it's a great question. I think it's really about trust, right? I think the idea that there's an AI agent that's going to either listen in on our conversation and help me with my documentation. Well, I don't know, how do I feel about that? Or as an AI agent that's going to call me and remind me that I need to check my blood sugars or get my mammogram or do something else like that. So there's a trust issue that has to happen with patients and patients' families, and there's a trust issue that has to happen with providers and health systems. Part of that's about the governance, is being able to say, this is how we're monitoring this, this is how we're validating this process, and this is transparent, and you can sort of see what we're doing. But the other piece, I think, is just, touch and feel. People have to get a sense to see what this looks like. Our strategy is really to do sort of a stratification of risk of the things that we want to use an agent to do. So if an AI tool is going to be interacting, it's fairly low risk to just remind you that you have have an appointment coming up, and have a conversation with the patient to confirm that they're coming in. Then we start asking them about their medications. Then we may start asking them about their gaps in care. So our expectation is to really build trust and see that, like for most of us, we don't think that much anymore of our interactions with Alexa or Siri, right? But those and people have those experiences. But when you bring it into healthcare, people get a little more nervous. And to me, that's one of the things that I see as our usability challenge moving forward, is really, showing leadership that we have a safe and effective product, but that also show to get that trust and buy-in from the end users.
And
Yes, and Ivana.
yeah, and that makes a ton of sense, PJ. I would, from our experience at IMO Health, answer it in more of a technical angle, which is the integration into all of these systems is so complex and nuanced. And even if you have the same system, EHR, data repository, that implementation is unique to that customer. And so once you think you've learned how a provider organization that's on EHRX is using it, you're completely wrong when you go to EHRX at hospital B. And so the barriers to user-centered design is strictly scale, at least from our organization's perspective. And, I would say we've been around for over 3 decades. Really, the way we've successfully overcome that is just brute force and sitting down with as many customers as we possibly could to understand how they document so that we could get it right. But it is a massive barrier. And it's so interesting when, big tech comes into healthcare and is like, this is an easy problem to solve. I don't know why you haven't solved this yet. That is the biggest barrier.
You're right. They see the integration challenges and they're like, nope.
Yeah.
That's way too much to handle, right? And that is a huge challenge. And it does seem that, that trust is critical, and that just seamless integration into their current workflows is critical. And, it taking all of those together to marry well and to work. So I'd love to hear an example of how where better clinical data led to a clear improvement in patient outcomes or organizational performance, and just kind of talk through some great success stories. I'm sure everybody wants to hear them. Like, where is this actually working well right now? And then we'll talk about, lessons learned and maybe what we're excited for in the future. So, let's talk about it. Heather, let's start off with you. What's a great example of when clinical data worked?
Yeah,
Good.
absolutely. One example I was just thinking about is when we get it right, when providers start using Suki in their patient visits, we've been able to show, by getting all of that accurate data and being as accurate as possible in clean data, we're able to capture a more complete, a more robust, accurate note. And so our providers have seen a 6x ROI with an average of about $1,700 a month in revenue, which is huge. ROI is always important. But for me, I would say what I really gravitated towards was the improvement we saw in the provider, the doctor satisfaction. So we all know that, especially primary care, and PJ can talk way more about it, but there's a shortage and they're burned out, and many are leaving their profession and telling their children that maybe this isn't the right profession. And so seeing and talking to these providers who, their burnout is dropping, they're going home to see their children at night, they're not documenting all night. To me, that's just such a huge win. And that translates also to the patient. So the patient feels that the provider is engaging more. They're not sitting behind the desk, of their computer charting. And so we've seen improvements in patient experience scores. So I just think you've got the ROI, but you've really also got the amazing experience that both the provider and the patient are getting.
That's awesome. PJ, I'd love for you to answer that question about some great use cases of clean data being used well. And then I'd also, as part of this, would love to hear your thoughts on the question in the chat regarding population and diversity, and how do we make sure that these tools are incorporating that and are ensuring equitable treatment across different populations and care settings, as the value-based care guy.
Awesome. Yeah, no, I can probably answer those with a single anecdote. I do want to sort of like tag on to Heather's comment just a little bit, in that I still see patients a few days a month in the office, and my partners think it's adorable, but because I come in and I see 8 patients in an afternoon, and I'm like, oh, this was so hard. This is really like, how did I do this for 30 years? And I think that is, I think, the other aspect of this is that one of the big problems to solve. Yes, we want to give better patient care. Yes, we want to have better patient outcomes. We want to do all those things. But another stakeholder group which is really suffering are physicians, and especially primary care physicians. And I know there was something in the chat about inpatient hospital settings, and I'm not an expert in the ambient space there, but I can say that we certainly want to keep on our radar that some of these solutions really need to be focused on that experience that Heather just sort of described of getting home. And not having to log back in, which is the pajama time question. Regarding the data, I think the one exciting thing, which predated my tenure here at Lumeris, that the team is really proud of, and I think has been exciting, is the ability to ingest publicly available consumer data and analyze that for looking for social determinants. And I think, one of the things when we look at social risk factors, it is part of that more comprehensive picture of the patient. And we think about that narrative, or who is this patient, and understanding and knowing who they are. Yes, there's the current medication list, and there's the however many ICD-10 codes that are in their chart, but that isn't really the whole story. And so being able to expand that to other data sources, but then they have to be ingested and they have to be analyzed and they have to be brought in. Our team is able to do that with our value-based care enablement partners. And then looking to say, like, how does your health system want to use this and deploy resources to make sure that those patients who have transportation problems get to their appointments, and those patients who have affordability problems have someone who can help problem solve their medication acquisition challenges. We really think that is a way where we can kind of be looking at a population and identifying where the biggest risks are, not just the biggest health risks, but the biggest social risks, and making sure that an organization has the ability to deploy resources in a way that makes the most sense for them. Finally, I'll just also say that this is one of those areas for me personally that I always think that AI can be both the problem and the solution with respect to health equity. It's a place for us, if we are diligent about the kind of data that we are collecting, normalizing, using, and deploying, we could do some really great stuff. If we are not thoughtful and really thinking about the populations that we're serving and the ways that we are reaching out to all the patients in that population, we could make this worse. And so to me, this is a bit about focus and intention of the organization.
Absolutely. And I think it's a way to see the person more than the data point, to see them as the whole system. And like, if you don't have clean, relevant data, if it's not incorporating that cultural background and biases and experiences. And so it truly is critical. Ivana, I'd love to hear from you about some success stories about when clinical data did it right.
Yeah, maybe a very specific one, and Heather mentioned how important ROI is, and of course ROI to our customers is front and center, especially when they're making major investments in tech. And as physicians use dictation more and more through this ambient technology, but also various notes that they've been documenting in the EHR directly, there's a criticality in extracting the right level of data from that note. And it's not just what is the context of a given sentence, it's that note plus the history plus really all of this disparate data that's coming in about this patient. And one of the more recent kind of technology advancements we've made at the business is something that we've called conjunctive logic, which is really taking a term from a part of a note and context from a different note or the same note and merging it together. As an example, diabetes mellitus type 2, and there's a reference to chronic kidney disease. Documenting those together is very important when you think of things like reimbursement, to the extent that if those were documented separately, you would get perhaps between 50 to 60% of that actual value, if anything, depending on how your health plan contract is structured. So just thinking about the importance of documentation, pulling out the most kind of accurate representation of that patient, has, of course, plenty of patient safety, reporting, population health, research implications, but also significant financial as well.
Fascinating. Now, somebody asked you a question in the chat. Have you seen success with any specific standards or ontologies like fire, SNOMED, in terms of retaining human context to the data pipeline?
Yeah, so fire, as all folks know, there is a requirement for all EHRs and other health tech organizations to leverage fire so that it's an open exchange of patient data. However, similar to what we were talking about earlier, every fire implementation is different depending on that organization. So a fire implementation again at EHRA is very different than EHRB, and some fields may or may not be exposed. And so you don't really get the true picture of the patient depending on how you're pulling it. That being said, there's other ways to get at the data, and SNOMED, UMLS, some of these more open source kind of ontologies are good, but they don't get to that clinical specificity that we've been talking about. That's not what the physicians use to document. And so if you just use that, you miss so much fidelity as it relates to the view of the patient, the true view of the patient.
Absolutely. Very interesting. And, as we're kind of thinking about lessons learned from all of these experiences, whether it's lessons learned from cleaning up the data or lessons learned from using that cleaned up data to improve things, like I'd love to hear about unexpected things that really surprised you or insights that came to you in your experiences of these things. So, Heather, I'll have you start.
Awesome. Yeah, so really, I would say something unexpected that I wasn't prepared for, and I've been in working in healthcare for almost 20 years now, was the amount of gratitude and joy that I've experienced from providers and practices and systems. Personally, two of my very best friends are doctors, primary care. And so I know the pain that they have, but I think the first time I've ever been hugged by a provider or doctor, she was a doctor that I did not know personally, was after implementing Suki. And it just comes down to they're making choices. Do they want to continue this profession because they're working all hours of the night and they're missing family time, they're missing friend time. So unexpected, I would say just the gratitude and joy, which, makes my heart full.
I know I've kind of seen that too through different providers that have told their great data stories. It's like a kid playing in a playground because
Yeah.
they're not just they're like, wow, I wanted to be able to see all of this info that was relevant before, and now I finally can. And, it's like they can do research, they can do things they want to do, look into, and it's pretty cool to see. PJ, I'd love for you to tell us any unexpected lessons or insights, and it can be good, bad, and in between that you've experienced as an organization.
It's hard to follow up. Like I'm in healthcare IT for the hugs. Like, man, that's that's a standard for all of us. I love that. I would say for me, one of the surprises that I've had, and I continue to be surprised by, is something that Ivana mentioned, and I remember um, our first EHR implementation, and this was, more than 20 years ago when I was in practice, and I was the tech guy in our small practice, and I always, the old saying, the one-eyed man is a prince among the blind, and so I was supposed to be like figuring out how to sort of get us on this EHR, and I remember speaking with the vendor and saying, that can we get, can we get the lab data from the lab that's across the street and associated with our health system? And the lab said, yeah, it's all in HL7. I was like, HL7, great. Everybody talks HL7. That should be that should be easy, right? Like, oh no, 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 that's not easy. And it took us years to get a lab feed for structured lab data. Again, that was early on, and I thought, oh wow. And then, we now have all these fire standards. Like that should have fixed it, right? But no. So 25 years, almost 25 years later, we're sort of still having the same conversations. And I think one of the things that surprised me a little bit is the extent to which things are sort of the same. Our ability to acquire data and it just takes a lot of effort. And for the average practice, they don't have time or resources to devote to all of these things that we that we see as essential to understanding about the patient and knowing them and delivering care. And they're expensive, right? So not every data feed is free. And how we manage them. And, from a health system point of view, every time they invest in their data governance or get new data or do something, they have to pay for that. And it's not nearly as sexy as the other things that they can invest in as an organization. So I guess part of me is surprised by the fact that, we're still struggling with a lot of the same challenges in this space.
Yeah, that is interesting because you think, oh, post COVID, we did so much innovation during COVID, so it's solved, and it's no, there's still some of the similar issues from even before then. Ivana, I'd love for you to answer this too.
Yeah, I mean, just to piggyback on PJ, it's not until there is specific regulatory requirements that this stuff changes. In addition to just how hard it is to get the data, even when an organization decides to make an investment to make their data more accessible and easier to understand, it is a massive re-architecture of their entire data model. So it is not just an investment in software, it is actual development work and time taken away from their own roadmaps and focus areas to do these things. So it is extremely complex and nuanced.
And we have a great question in the chat that we can kind of continue on. These questions could not be better. They just are just leading right into one another. Ivana, this would be for you. What strategies have you seen work well for identifying and addressing any blind spots that arise when patient data is overly simplified for reporting or modeling, especially when those simplifications risk masking important variations in patient behavior or outcomes? And I think that is kind of a challenge that some folks have seen. Has IMO experienced this, or any of you, have you found strategies that supported or helped your organization?
I mean, this is outside of our provider business, really the primary use case. I mean, we have this patient population that we're trying to understand, but there's so many gaps in the data that's come through, and can you help us fill those gaps? And typically where you see a lot of that data living is in unstructured text. It's in blobs of data that gets sent over that was never pulled out, standardized, or structured. And so this is where Gen AI and these agentic models play a huge role in helping to further that innovation.
Heather, have you found strategies that worked well for this particular challenge?
Yeah, it's to Ivana's point, it is there's so much unstructured data that is kind of the gap that we see also, is how do we normalize that data so that we can use it to inform the output and inform the provider. So, from our standpoint, the strategy we've taken is going back to our clinical knowledge graph, which is we built this layer so that we can continue to feed more inputs and more signals into it, so that we don't risk being oversimplifying the output. And so, one of those examples is we produce a patient summary for the provider before they walk into the room. The only way you can do that is to get additional data outside of that patient visit, right? So it's really about ensuring that you are getting these multiple signals and not just one signal.
Yeah, absolutely. I kind of wanted to shift a little bit because we had a question in the chat speaking about bias once again. And PJ was following up on a comment that you made. The question is, given the longstanding challenges in achieving truly connected clinical data, and the bias this fragmentation is introduced into provider decision making, what do you see as the next evolution in overcoming some of these bias barriers in healthcare clinical data? Yeah.
Yeah, it's a great question, and obviously one that we could have an entire session on with people smarter than me. I wish I had a reference for it, but there's a paper that I read about bias a year ago, that was about a year ago, that where they looked at sort of bias in healthcare IT, and interviewed all these people in this qualitative research, and found that basically physicians think of bias in one way, in the sort of kind of a health equity lens. Technology people think of bias in a completely different way, and health ethicists think about bias in another way. And so part of the challenge we have when we think about bias in healthcare and AI in health technology is that we don't even have the same definitions or nomenclature for what we think about. And personally, I always think of examples like, you know, the the research that fuels a lot of our evidence-based treatment guidelines comes from data that was collected on people who look like me, and not necessarily on other populations, on women, on people from other race, ethnic groups or socioeconomic groups. And so we still take all that information and then we put that into our guidelines. Those are sort of inherently have a problem with bias within them, and then we're using them and distributing them throughout the healthcare ecosystem as part of our recommendations and clinical decision support. So we already have some underlying bias in the overall systems. I think to me, the way for us to think about this is, you know, what are agreeing on some definitions, and then really this is a place where regulation needs to help us as well, to say what are the things that a system that has an AI system in healthcare that we need to do, so that we're sort of looking across platforms, technologies, and things, and we have some common nomenclature and common ways to say what we're doing to measure the interactions that we have. You know, whether it's population health based or whether it's patient interactions or whether it's clinical decision support, all of them have areas where we could do that. I think we have a lot of work to do to get closer to a system that we can all trust.
Yeah, that makes a lot of sense. And there's so many different types of biases. So let's all agree on what biases we really feel are impacting what's feeding the system and coming out of the system in clinical decision support. I think that makes a lot of sense and is part of that quality effort of making sure that data is quality. Why I want to kind of, wrap up this conversation and talk about why is it important that we see the person behind the data point when we're building healthcare technology solutions. Like, why is the mom rule, like seeing every data point as your own mother? Like, why is that important? And I'll have Heather start this off.
Yeah, I love the why, because it's just, to me, just so important, because at the end of the day, healthcare is about people. It's not charts, it's not codes, it's not this or that. It's truly about healing and taking care of other humans. And so if we only think about it from when we're designing the workflow or we're thinking about data capture, we risk that human connection that's really at the heart of care. That's why we're here. So every decision we make at Suki is always about thinking about how this will affect the relationship between the doctor and the patient. Technology, like in our mission, which is to make it tech invisible and assistive, is truly that, so that the doctor or nurse can be present, listening deeply, and treating that person as a human, and not just a chart. And that's the why for me and the why for Suki.
Fantastic. And PJ, I'd love for you to answer this too. Like, why for you guys?
Yeah, it's sort of coming back to a little bit of what I talked about before. I think for us, the important aspect, sort of going on some of what Heather mentioned, is that if we're thinking about agentic systems and the ability for them to help to transform primary care, there has to be a what's in it for me for everybody in all of the stakeholders, and it has to fit into their day in a way that feels like it's adding value and not adding an extra thing I have to do. And I think, physicians have been told for many years, since we first implemented our first EHR, that like, this is going to make things better. Like, you can't believe it. You're going to have an order set. How awesome is that? And like, aren't you going to be thrilled? But there were no hugs then. And I think I think for us, a lot of the why here is like, can we take all of these different data elements that we have from so many different places, can we think of an AI ecosystem that helps us to support patients, providers, and deliver insights that really make everybody's life better? And that's a big goal. It's a big thing, and we recognize that. But that's really the why here, is to say, rather than seeing all these different data points, we could turn those into insights, and those insights into actions that improve the experience of everybody in the healthcare system.
Fantastic. And Yvonne, I'd love for you to answer this as well.
Yeah, I actually have a personal story. I mean, I think everyone has their own stories, right? So recently, my husband had a hip replacement back in November, and considered very low risk. He's young, he's healthy, so he had the procedure at an outpatient center. Was discharged within 90 minutes of the procedure, which is mind-boggling to think about after such a major joint replacement. And within 24 hours started to experience some serious complications, not related to the hip, but related to the anesthesia and pain meds. And so hourly conversations with the orthopedic surgeon, who was kind of like, I don't know what's going on. You should talk to your PCP, talk to the PCP, who was kind of like, this is beyond my pay grade. I don't know. You should maybe go to the hospital. Went to the ER multiple times. And each of these times I had to aggregate his record because there was no consistency across any of these systems. There was no reference to the 20, and I'm not exaggerating, medications that he was given after the surgery and what he was actually taking. The ER treated his symptoms, discharged him, still getting worse, went to a urologist who didn't know what to do. It wasn't until a family friend who happened to be a doctor took the time to actually review my documentation in detail and actually feed it into AI and to review various medical publications with similar symptoms, with different outcomes, and actually put him, of all things, on an Alzheimer's medication as an experiment, just to see what would happen. And it worked. But if I didn't have the wherewithal to put all of that data together, to have someone who actually would take the time to review it and go through that extra step, we would be in a very different place. And so my why and a lot of what we do here is to never have anything like that happen to anyone else.
Patients and caregivers should not have to bear the brunt of health record fragmentation in this day and age. It's absolutely unacceptable. As a patient advocate working in numerous health systems, helping patients navigate healthcare, I've seen it time and time again where their records aren't where they need to be, and time is brain, time is heart, time is not on your side when you are sick and you are suffering. So, the sooner you can get to a specialist, the sooner you can get to an answer, the better. And what I love about that too is utilizing AI. I mean, patients and caregivers are utilizing AI more than ever. Physicians are using AI to support them. And without that solid clinical data, architecture, structure, strength of the data, like you're not going to get great answers outside of it. So that was a fantastic way for us to kind of move on to what do you hope is the next step in clinical data in 60 seconds or less? Like, what do you hope we can do with this great data moving forward? Yvonne, I'll have you start off.
Empowering patients to advocate for themselves, empowering providers to make better decisions at the point of care. All of what Heather had said at the beginning around, the Suki mission, that's what this is all about, is that the tech is there. We need to get our data to a place that enables it.
And PJ and Heather, I'll have you say the same. Like, what's your big-eyed dream with good clinical data?
Yeah, I mean, it's honestly what Ivana said too, and adding to her story, I want to be able to take my daughter to the ED and they know exactly what has been happening, because I've had my own story similar. I walk in with all the records, and guess what? The four of us are educated in healthcare enough to know we can do that. Most of the population is not. So I want to make sure everybody has that same experience, but it's not on them.
And PJ, from your experience as well.
Yeah, I just have to say that those were two really impactful answers and responses, and I agree that to me the challenge here is in order for AI tools to be useful. I'm very struck by Ivana's story. It is she had the data, right? She had it there, and she could use an AI tool to get closer to a response, but the data needs to be in a way that our new technologies can actually analyze it, aggregate it, analyze it, and deliver the insights for the clinicians. So that's what I'm hopeful about is that clinicians won't have to work so hard, but also that patients won't have to work so hard to get those data elements together for us to be able to deliver better care. So I think that's really the place for us to keep working.
Fantastic. Well, thank you so much, PJ, Heather, Ivana, for sharing your wisdom with us today. And thanks to all of you for joining us and being a part of this important conversation about human-centered innovation in health tech. And thanks to all of you for being at the forefront of making this happen. Let's keep the momentum going. Feel free to connect with me and the others on this panel on LinkedIn to continue the discussion. We'd love to hear how you're centering the patient journey in your own work. Until next time, stay tuned. Thanks so much, all.
Thank you to IMO Health and to everyone that joined us today. Please visit our website at community.hlth.com to catch up on all Health Go Live webinars and to watch the recording of today's session. And don't forget to join us in Las Vegas, October 19th through 22nd for Health USA.